Marijuana, also known as cannabis, has been used as an anesthetic in surgical operations for thousands of years. It is considered an illicit drug in Australia, but has now been proposed as an alternative relief from chronic pain. Marijuana contains delta-9 tetrahydrocannabinol (THC), cannabidiol, and cannabinol. THC produces psychotomimetic and depressant effects and peripheral effects, but this presentation is concerned with its analgesic effect. CB1 and CB2 are G-protein coupled receptors, and they are the sites of binding of endocannabinoids and cannabinoids. CB1 receptors are concentrated in the central nervous system, including areas that mediate perception of pain, while CB2 are found mostly in the immune tissues and absent from brainstem. Activation of CB1 leads to inhibition of synaptic transmission. A delta fibers and C fibers transmit pain stimuli to the dorsal horn of the spinal cord, which then relays the impulse via the spinothalamic tract to the cortex for higher processing. The cortex then activates several descending pain control pathways. GABA is one of the descending pain pathways which inhibit the excitatory transmission that originated in the nociceptors. Periaqueductal gray (PAG) and rostral ventromedial medulla are involved in descending inhibitory pain modulation. These areas project to the dorsal horn of the spinal cord and inhibit pain transmission. CB1 receptors are found in high levels in brain and also lower levels in spinal and peripheral nervous tissue, which are important areas for pain perception. This is a quick animation about marijuana's journey in the body. Endocannabinoids activate CB1 receptors located presynaptically coupled to G protein to inhibit adenylate cyclase, decrease calcium influx, and increase potassium efflux. This in turn inhibits the release of the neurotransmitter GABA. As a result, the pain processing loop driven by nociceptive afferent fiber input is eventually suppressed by descending anti-nociceptive output. CB1, alpha-2 adrenoceptor, and mu-opioid receptors are all G-protein coupled receptors sharing signal transduction pathways, such as inhibiting adenyl cyclase and modulating potassium and calcium channel activity. These receptors also have a similar distribution in the PAG and substantia gelatinosa, areas in the central nervous system involved in anti-nociception. Both alpha-2 adrenergic or mu-opioid receptor agonists show significant synergism in anti-nociception when combined with a cannabinoid receptor agonist. Vaporized cannabis has been shown to enhance the effect of morphine analgesia in chronic pain. It appeared to slow the absorption of morphine. A study on the efficacy of dronabinol, a synthetic cannabinoid, and an opioid for treating chronic pain showed that dronabinol decreased pain intensity and increased quality of life compared to baseline opioid therapy, reporting mild to moderate side effects such as drowsiness, but also improvement in sleep and overall satisfaction in the treatment as compared to placebo. Cannabinoids have also been shown to rekindle opioid analgesia after prior dosage has become ineffective. NSAIDs inhibit the enzyme FAAH, which is responsible for the degradation of cannabinoid receptor agonists. This results in the inhibition of the reuptake and degradation of the endocannabinoids, prolonging the pharmacologic effect. In summary, the following 2 points are the take-home message of this presentation. Firstly, through activating CB1, cannabinoids decrease pain by suppressing the descending pain inhibitory pathway. Secondly, the combination of cannabinoids with synergistic analgesic substances such as alpha-2 adrenoceptor and mu-opioid receptor agonists and NSAIDs improves the efficacy and safety of treatment. The benefit comes from a lower dose resulting in less adverse effects.